Okay, so I'll continue now with another topic, sensory innervation of the hip joint and referred pain. This is a systemic review of the literature, actually done by a France group, published in the British Medical Journal. Okay. So, introduction. Osteoarthritis of the hip pain is classically described as presenting in the groin and the anterior thigh, as well as the anterior knee. However, the anatomic distribution of the sensory innervation around the hip remains unknown. So basically, when all these OA of the hip patient comes, their site of the pain is very non-specific actually. Most of the time, they'll point towards the hip region, but when you ask them to pinpoint where is it, they usually cannot really tell you the exact spot. Okay. So Lasher actually found that the patient with hip pathology awaiting fluoroscopically guided intra-articular hip injections, most commonly they are presented with referred pain, mainly in the buttocks region 71%, in the thigh 57%, groin 55%, and the lower leg 16%. So this mechanism of the referred pain is actually poorly understood. So some authors actually hypothesize that the nociceptive dorsal horn neurons receive convergent inputs from various tissues around the fracture site, thereby preventing the higher centers from identifying the true input source. So the most broadly recognized theories are the convergent projection theory, wherein the somatic and the visceral fibers from the primary neurons converge on one of the dorsal horn and cause the referred pain. And also the second most common theory is the axon reflex theory, wherein the primary efferent fibers bifurcate to supply the somatic and visceral structures. So basically what this means is, at the fracture site, both the somatic and the visceral pain, they actually go to the same dorsal horn and cause confusion over the pain interpretation centrally in your brain. So that's why the pain is non-specific. So few authors have actually found that a few major nerves supplying the area of the referred pain of the hip, mainly the femoral nerve, obturator nerve, and the sciatic nerve, the three major nerves surrounding the hip. However, there is still a lack of consensus with respect to the arrangement and the anatomical location of the sensory articular branch around the hip joint. So what's important is actually the neuroanatomic distribution of the sensory receptors supplying the nerve joint. So Gerhardt has actually found a high density nociceptors within the superior portion of the anterior capsule, which is a common place for the referred pain. This study, what they did is they found, I think, 21 articles and they reviewed through it. It's actually from 1945 until 2019, so it's quite an extensive period of time, including all the physical copies. So, the sensory receptor of interest majorly are focusing on the mechanoreceptors and the nociceptors. Both types were found in the hip joint capsule, its labrum and its ligament. So now let's talk on the anterior capsule. So Gerhardt has found that the highest density of the mechanoreceptor are in the superior lateral portion of the anterior hip capsule, while Tollefson had a similar finding with addition of decreasing densities in the superior medial and the inferior lateral directions. Area of the poorest in mechanoreceptor was found to be the inferior medial. So also noted that in the deeper layers of the capsule, they tend to have more nociceptors than the superficial layers did. As for the nociceptors, it has been identified that the center of the superior most aspect of the anterior capsule has the most nociceptors with a gradient decreasing in density medially and laterally. And this one later I got a diagram to show, summarize. As for the posterior capsule, the highest density is of the mechanoreceptor has been identified again in the superior region, but this one is in the lateral, superior lateral portion of the posterior hip. So a small numbers of receptors was identified in the inferior capsule too, and they were nearly non-existent in the central and superior medial capsule. Nociceptors wise, the literature is significantly more sparse. So in the posterior capsule, actually they found that very rarely they can find nociceptors there. So only 2 studies found nociceptors lah, and they were both contradictory. One they found more in the inferior, another one they found more in the superior lateral region. As for the labrum, the anterior superior part of the labrum had the highest density of mechanoreceptor lah. Azharani also reported a high density of mechanoreceptor in the posterior superior, inferior, and anterior inferior labrum. So both this group actually found that the superior lateral and the posterior inferior aspect of the labrum to be poor in a mechanoreceptor. Nociceptor density was found to be highest in the superior labrum. Whereas in the ligaments, they have found both mechanoreceptor and nociceptor in the ligamental teres. Jihad also added that the density of this mechanoreceptor was very low, and he was unable to find any nociceptors. Haverset actually found a very high density of nociceptor in the middle of the ligamentum teres, while receptor density decreased as it moved closer to the acetabulum and the femoral head within the central part of the ligamentum teres. Within the transverse ligament, they have also found both mechano and nociceptor. And for the 3 primary fibrous capsular ligaments, they found a moderate density of mechanoreceptor. So actually this diagram summarizes where all the mechanoreceptors and the nociceptors are most commonly found based on all the major studies that they compiled. So actually, I think to remember easily, I think just remember superior laterally lah. This is the see, this side is the anterior side, posterior side. So most of them actually is found on the superior lateral. The inferior side also in the superior lateral region. For the nociceptor, actually same also lah, with decreasing intensity over the superior region and the inferior region. Right. So this is a summary of the nerves found during all their cadaveric dissection based on I think about 12 studies like that lah. So so you see the distribution in the anterior and posterior capsule is basically got 2 main groups of nerves. For the anterior capsule, most commonly found are the femoral nerve, obturator nerve, and the accessory obturator nerve. Whereas you see all the studies, the highlight in red ones are like that. As for the posterior capsule, the major nerve supply will be from the sciatic nerve, superior gluteal nerve, inferior gluteal nerve, and the nerve to the quadratus femoris. These are all the major studies that they compiled the info from. As you can see, most of them are actually cadaveric study, with only the recent 2 ones are clinical studies. So again, it's almost the similar findings of the nerves. So this is another diagram that summarizes the major supply of the hip region. The left side is the anterior hip, while the right side is on the posterior side of the hip. So again, the same thing, femoral, obturator, and the accessory obturator nerve is mainly supplying the hip region. Whereas the posterior part is the sciatic nerve, superior gluteal nerve, nerve of the quadratus femoris, and the inferior gluteal nerve. So, interesting, see the distribution. Okay, this is the anatomical diagram. See, this picture actually got quite some amount of info. They actually highlight on the green part actually is the mechanoreceptors. With the most green part will be the highest density and the lowest one will be the lighter green color. So as you can see near the IT there is actually high amount of mechanoreceptor. Whereas the posterior hip part actually you can see the colors are generally more lighter. So actually most of the pain due to the movements of the hip is mainly from the anterior capsule. So when you position patient, or the movement itself, stretching of the mechanoreceptor actually causes most pain in the anterior aspect. So the red one will be the nociceptor density area. Again, you see it's actually mainly in the anterior hip there, the midpoint there, where most commonly all the fractures happen in the elderly. Whereas the posterior part, not so much of the nociceptors. So as for the nerve supply, You can see the main major ones is femoral nerve, obturator nerve, accessory nerve. So all of them has their articular branch towards the hip joint. The posterior part, actually the sciatic one actually only a small branch, as the main branch is actually they found to be the nerve to the quadratus femoris, which is the most lightest yellow part. So I think from this diagram you can see how like blocks like pink works because basically you do a major nerve block, maybe you can cover only one of the major nerves, like femoral nerve, obturator nerve, you can cover only some of it. But you give blocks like pink block, it actually seeps into the articular joint, basically blocking all these articular branches. This is my take on this graph. So the discussion of the study is the resulting frequency map of the articular branch and the sensory receptors of the capsular ligamentous structures of the hip joint provides an anatomic basis to explain the patient's symptomatology and may improve the diagnostic ability of clinicians. So I think what this statement means is that when you encounter someone with a hip fracture, you should, based on what you know now, you should actually inquire more, like try and localize where the pain is. Then you know which is the major nerve that you should consider to target during your blocks. Like if the patient complain more of the back pain, referred buttock pain, then maybe it's more of like all the sciatic, the nerve to the quadratus femoris, all these kind of blocks. So the innervation of the hip joint capsule consistently involve three major nerves, as mentioned just now: femoral nerve, obturator nerve, which supply the anterior capsule, and actually for the posterior is actually a nerve to the quadratus femoris. The other four accessory nerves, the superior gluteal nerve, inferior gluteal nerve, accessory obturator nerve, and the sciatic nerve, actually they are all inconsistently found to supply the posterior and all anterior capsules. So the three main ones to remember is the femoral, obturator, and the nerve to the quadratus femoris. So area of the densest nociceptive innervation was in fact the superior portion of the anterior capsule, which we saw in the diagram just now. This rich capsular innervation may explain why some of the pain associated with osteoarthritis and the synovial inflammatory process that stretch the capsule during mobilization. They also found that the posterior capsule had a relatively poor nociceptor density. Despite it having a lower nociceptor density, they did find that the posterior capsule was consistently innervated by the nerve to the quadratus femoris. Furthermore, the posterior superior labrum, rich in nociceptors, was also found to be innervated by the articular branch of the superior gluteal nerve. The postulated that these two nerves actually contribute to the posterior or the buttock, the type of referred pain from the hip pain. They also hypothesized that the sciatic nerve actually plays a lesser role in the referred pain from the intra-articular hip pathology as compared to the superior gluteal nerve and the nerve to the quadratus femoris. Buttock pain associated with sciatic nerve compression, including piriformis syndrome, ischiofemoral impingement, and the proximal hamstring syndrome, must be differentiated from referred pain in the setting of degenerative hip pathology. So what it means is that if there is buttock pain, could be due to the sciatic nerve compression, and the fact that based on all these studies, they found that the sciatic nerve compression doesn't really contribute much to the hip pain region. So you have to think more of further differentials when you meet with such condition, including all these syndromes that was mentioned. So the mechanoreceptor density was found to be higher anteriorly than posteriorly. So the anterior capsule, reinforced by the iliofemoral ligaments, most importantly the superolateral femoral fibrous branches, plays a role in the hip stability and protection of the joint from edge loading. The absolute density in the superolateral portion of the posterior capsule is less than found in the anterior capsule. They posit that the muscular tendinous structures, including the short external rotators and quadratus femoris, play a larger role in the posterior stability than in the anterior stability. So So the limitations that they found from this systemic review is that actually there's a low number of specimens in each study, mainly because it's all cadaveric studies. And there's actually also different methods of dissection. So a lot of studies have contradicting findings because the way they dissect also is not following standard protocol like that. Then the inherent risk of elongation or complete transection of the small articular branch may also contribute to the variability in the study, in the number and cost of the described articular branches. So the future directions based on this study is that percutaneous radio frequency ablation of the articular sensory nerves around the hip joint or the dorsal root ganglion stimulation may be an appropriate minimally invasive treatment in patients who are not candidates for surgery and for those with severe post-op pain. So all these findings, they can actually start doing things like very targeted nerve radio frequency ablation of the articular branches of each individual nerves. And based on the symptoms itself, they can target whichever nerve that they think is contributing to the pain. So Gupta has demonstrated that a moderate short-term reduction in pain after radio frequency ablation of the anterior capsule in 53 patients. So actually someone has been doing this now itself. And the doctor positive results also exist for the use of a dorsal root ganglion therapy, focus on the L2 to L4 obturator nerve and the femoral nerve mainly for the post-surgical hip pain. So conclusion take home is these three major nerves were found to consistently supply the articular branch to both the anterior and the posterior capsule of the hip joint. And there's also evidence that the not so important nerves, the four nerves, contribute to the hip joint innervation, though with less consistency. The anterior capsule primarily supplied by the femoral and obturator, and the superior labrum appears to be the primary pain generators in all these hip fractures, given their densities in the nociceptor and the mechanoreceptors. With that, I conclude my talk.